So now we move on to our keynote from Zhonnet Harper. Z is a community-based cancer patient advocate and thought leader. She's also a breast cancer navigator at Alameda Health System, where for 10 years she has navigated the twin ravages of cancer and poverty and their devastating impact on individual and community health. Advocate of racial justice and equity in healthcare, this means contending with the intersections of race, class, and place-based inequities within healthcare and social safety net system. She's also a proud member of Umoja Health, founded and led by Dr. Kim Rhodes, yes, along with being a member of the Community Leadership Board for the Wisdom Study, founded and led by the incredible Dr. Laura Esserman. Next up for Zhonnet is the launch of her own project, which focuses on whole family care system supports and interventions, specifically for cancer patients and their families. Welcome, Zhonnet. How are you?
Fine. How are you?
I'm doing great. I cannot wait to listen and receive. So we are all ears.
Oh, well, thank you so much for having me, you guys. I'm so humbled and appreciative to be in the company of so much greatness. I'm also a little stressed because I'm coming behind Dr. Kim Rhodes in the fantastic presentation prior and dealing with Nikki in your hair. So I'm gonna do this real quick, try to make sure I'm on point before I get started. Again, my name is Zhonnet Harper. You can call me Z, and I am a breast cancer navigator. Professionally, I work for Alameda Health System, but my commitment to breast cancer is to the entirety of the cancer community. It was really hard initially for me to think about how to present today, being a Black woman, because I just believe that part of the reason why we suffer from so much inequity is because we don't present ourselves, our full selves. We are more than our diagnosis, and we should always remember that. And we should walk in as more than our diagnosis, regardless what the reason is. I thought about one of the questions in regards to why do African American women have a higher breast cancer burden? And I just thought, it's the American way. What burdens don't we carry disproportionately as Black women, as Black people? And it pained me to say that breast cancer is no different. And a lot of that has to do with because we're working within the same systems. You know, I'm to a point where I hate the word social determinants of health. You know, poverty don't have a happy hour. And I just feel like it's structural determinants of health. And we need to really be more intentional about focusing in on structural determinants. Those structural determinants are the same determinants that created redlining, that have a lot of our cancer patients living in substandard housing today. A lot of those determinants that we talk about around transportation stem from the way transit lines are structured, that take no consideration of cancer patients and their inability to maybe take a few extra steps because they're tired from chemotherapy. So we're dealing with cancer as a disease, but the burdens are an outcome of structural determinants in racism. And we don't often have those conversations, I think, because sometimes they're just really heavy. They're overwhelming. For so many of us that have been in this fight, you know, whether it's as a caregiver, whether it's as a professional, or just exhausted just from being Black, quite frankly. And we don't know how to quite process it because these aren't conversations that we can really have within institutions that are, you know, plagued by white supremacy. You know, and I'm really just trying to be calm in saying this. The last few years were very tough for all of us. But if you're a person who works with cancer, it was especially tough. Because as a cancer navigator, and for those of us who have been touched directly or indirectly by cancer, to watch people struggle with insurance, to watch people struggle with how to bury their loved ones, to watch people try to survive off of a meager pittance from unemployment, and then COVID come out, and then, honey, everybody getting some money, restaurant tours, they're getting burial assistance, they're worried about, honey, their kids and their mental health. And it just took everything out of me not just to flip out, because I'm like, wait a minute. Our cancer patients have been undergoing these same horrible types of conditions, and nobody said anything besides those of us who work in it. And now COVID shine a light. I thought I was going to pass out. I thought if I go to jail today, it's Friday, I'm not going to see a judge until Monday. What you mean it's shining a light? Is that to say we weren't seeing, even in our most vulnerable state? Cancer patients suffered the same thing, and they continue to prior to COVID. Cancer has been around since what, the 17th century? And COVID has been around or widely acknowledged since what, 2018, 2020? And they get a CARES Act and we get a moonshot? I don't understand that. And in the meantime, as people who work with cancer patients, their question is, who cares? And if you got COVID, you get pointed to the CARES Act? See, these are the problems that I feel like we need to bring just to the forefront and be very, very intentional. And I actually see it as an opening, because now we can talk about equity, because somebody needs to explain to us, what's the difference between the COVID patient and the cancer patient? They both are suffering economically. If they're parents, they both have children. If they're housing insecure, they need help. If they're entrepreneurs, they need business assistance. So my thing is, in a way, this kind of can catapult us further along in the discussion of equity, because now we have a real model. Because if it's not about providing equitable treatment to the cancer patient, then what is it? Then that means it's economic. And if it's economic, how are we valued? Now we get into the system of devaluation, because really at the core of our burden, that's what it is. Black people are not valued to the extent that we should be. We are monetized, don't get it twisted. That's why a lot of times people don't show up until it's a funding stream. Oh my God, now they know us. No funding stream, they don't know us. And so in that regard, we need to step up our awareness into when we are true partners and when we are options that are being exercised within those partnerships. See, the thing that makes organizations such as Roots and Umoja and other organizations so successful, they're there when no one is looking. They're there when there aren't any funding streams. Not to say that they don't need them, but they don't leave. That's not, that wasn't what was the reason for them coming to us and serving us and helping us. It was out of compassion. And just understanding the humanity of who we are. And as Black people, we need to be more intentional about our humanity, because it's so easy to dismiss us when we make it just about our disease. Oh, well, there's no funding for that. Okay, but is there willingness to come and see about us anyway? Even if you can't do nothing but just say, hey, are you okay? Can I offer you a referral to a different system that may provide something for you that we don't have? That's what Dr. Rhodes does. And again, I'm really trying not to come off as really angry or, a full-blown rant, but it's tough, because we don't have the conversations. I'm a navigator, but at the end of the day, if I'm working in a system that's poorly resourced and I'm trying to help a woman that is suffering from being poorly resourced, and then I have to refer that patient into a community-based organization that's poorly resourced, I'm just a poor Black woman helping another poor Black woman go to a poor Black place. And then we wonder why the outcomes are what they are. we have to understand that what we're dealing with, it's intersectional. But the question for us is how many people are dying in the intersection? I turn on the news and sometimes they have on, say, for example, something about somebody getting hit in San Jose, crossing a dangerous intersection. Well, you know what? We got patients that's crossing dangerous intersections to go to siloed treatment that we mistakenly identify as a system. It's a system of silos. Because if every time you receive a service, it requires a referral, that's not a system. It's a silo. And there's so much more that we can do with these opportunities to really bring not just a comprehensive, but a compassionate approach to care. And you know, I just feel like we need to really not be afraid to bring morality back into the conversation. I feel like sometimes we get sidelined, sidetracked by the clinical. You know, I tell people, clinically, the patients, they'll receive treatment. But morally, are they receiving care? You can look at any system and you'll know where to get the treatment. There's a space for that. There's also a space for the billing. Know where that's at, but where's the care? How do we even determine it? How do we define it? Is it something that is unique to a particular program within a system? Sometimes there's fragmentation within a hospital system. Care for one department may not be care for the next department. So even our assessment should be more in depth. You know, and I'm gonna say this too. We need to really understand the challenges of Black leadership. Because oftentimes the challenges of Black leadership are the same as they are for Black patients. Not having access to the table, which translation, patient not having access to timely diagnosis. Okay? Not being heard. Doctor not hearing the patient. And then on top of that, the leadership may have the additional burden of not really being able to speak about it. Why? Because they have to feed their families just like everybody else. No different than the patient who says nothing about the physician, because they got to come here for their care. So a lot of times, it's not even about just the cancer. It's about our Blackness overall. And we have got to find a way to be better supports to our Black leadership. Don't think because they're a leader that they automatically heard, respected, and empowered. Okay? Because that's not always the case. And so I would really take this opportunity to say, when we think about systems and reimagining, that we keep that at the forefront of our mind, because our leaders, you guys, they are doing an incredible job, and it's a Herculean task. And I just want to keep us mindful of that, you know, because so much of our outcomes are dependent upon their ability to be empowered and to be heard and to be at the table, and not as a servant, okay, but as the host. We deserve to occupy all those spaces, and we don't. And again, I'm not trying to be mean or hyperbolic, but after 10 years, there are just some things that we really need to just be very honest about and grapple with. And understanding who we are in this space as Black people. You know, our Blackness, they see that before they see the x-rays or the screening or the pathology. Oftentimes, they see our Blackness, and oftentimes that's what's responded to. So we have to just make sure that they see us in our entirety. We're not Black. We're Black, but we're human first. And we have to not let our Blackness be our silo. Our Blackness is our blessing. And you know, I'm just trying to take this opportunity to be able to speak so openly and so frankly in front of an audience that I hope to God, you know, gets where I'm coming from and hears me. Because these conversations are oftentimes very private, because we don't have the luxury of not being of being heard, you know. And if we are, you know, it's because we're angry, you know, then we're angry Black, we're you know, disruptors, we're, you know, just troublemakers. And I say that from personal experience. And that was something that I actually learned to live with. And matter of fact, embrace. I thought, you know, hey, I'm from Oakland, deuces up, if that's what it's going to be. Until I actually started working with Dr. Rose, and she called me a radical healer. And it makes me want to cry because it changed so much in my approach to the work. And it gave me a sense of purpose that I always had, but better defined. I didn't feel so constricted in my speech because someone helped me understand what I was really doing. And we have to bring so much to the table, you guys, all the time. And I know it is so tiresome, but it is so necessary, because we have patients that live without hope and die without dignity. And that could be resolved to a large extent if we have a CARES Act, okay? Instead of a moonshot, how about a real shot, okay? A real shot at housing. Right now, we have cancer patients, they can't even get expedited housing that are coming out of chemotherapy and surgeries that have like minimal access to housing. And then on top of that, you have some housing operators that are afraid to take the patient because they don't want to take on the liability of someone being sick that they may or may not be able to care for. We have SNFs that need to be shut all the way down, if not burnt down. Part of the remedy to that is enforcement. There needs to be more enforcement. We really have to expand what we see as the continuum of care. And we have to reimagine what our resources are. Enforcement should be looked at as a resource, not an option. It should be mandated that housing for cancer patients, they have an expedited route, period. You have one for COVID, you put up hotels and honey, just did all kinds of stuff. But you mean to tell me I gotta refer a patient and hope that they can get some expedited housing because I'm linking it up with a behavioral issue? These are the kind of things that really make our patients not want to be a part of a system that does not see them. And when they do, it's only in terms of our burden. It's never our brilliance. It's never our potential. It's not our dreams. It certainly isn't our businesses. But then when you look at what they did for COVID, they saw all of that. So I'm using this as a moment to say, you know what? We don't have to reinvent the wheel. Let's just go buy 4 new tires and call them COVID and keep it moving. Because if they can't extend that to us, then that allows us to have a different type of conversation, because the work has already been done. Now, again, it goes back to what is so different about a cancer patient versus a COVID patient. And that's pretty much where I am with that. I don't know how to answer a lot of these questions as to why Black women are more likely to die from cancer, breast cancer, at a rate that is exponentially higher than white women, other than it's the same system, you guys. We're not operating in a different system because we have cancer. We're operating with an additional burden. And we have to just take it upon ourselves to address the system for what it is and realize that war is asymmetric. It is not lateral. If we have problems with transportation, then we need to be sitting on the Transportation Commission. If you have issues with the reason why patients aren't receiving housing in a timely manner, then see if you can get on a commission that addresses that. See, we are always dealing with the outcome. We should start with the governance. And then hopefully that will impact the outcomes in a way that is positive and that diminishes the suffering, because we recognize it, realize it, respect it, and are working towards the eradication of it. And it's almost to a certain extent like, if we're in a community-based organization, you know, they seek us for input, but our people seek us for more fuller representation than input. They seek us because they trust us. They seek us because we can carry the message forward out of a place of respect, dignity, love, and hope. And we just, you know, we need to start taking on a greater role in governance and not just be here for outcomes. So, you know, make sure people get the screening. Also, there is a new Cancer Care Equity Act, SB 987, and it is actually called the Cancer Care Equity Act, and it addresses complex cancer care in which, for example, triple negative cancer, they would be able, with Medi-Cal, to send you to an NCI cancer center to receive clinical trials. So there are some good things happening, but I just feel like as Black people, you guys, we are so overwhelmed. We're so overburdened oftentimes. We have so many discussions that we need to have, and our space is so limited to have those conversations that I don't know. I just felt like I needed to say this to you all today out of love and let you know. One last thing is that we talk about access all the time, but we have access. We have access to our brilliance. We have access to our determination. We have access to our commitment. We have access to love. We have access to hope. We have access to all of that. Our issue is money. We are the resource. What we need is money. And we need to be very intentional and very specific about that in order to do the things that we wish to continue to do and to start doing as it relates to cancer.
Ooh. Thank you so much. The title of Radical Healer absolutely fits, and we thank you for your passion for our communities and passion for this subject. Blackness is our blessing. It's like, is that on a t-shirt already, or can we do something and get that on a t-shirt immediately? And talking about the American way for Black women, it's like, you know, us being used to carrying these extra burdens, you know, powerful, very true statement, even if it is an unfortunate one, but it's something that, you know, I just felt very deeply when you said it. So thank you for everything. So we have some quick questions here. How do we empower the patient to advocate for themselves while acknowledging the necessity for Black leadership to impact systemic change?
What we do is we speak to the patient where they are. Sometimes, you know, we say things and it doesn't, we don't do it out of this empty space or to speak in a way that is just all rhetorical, but we don't put it in enough practice, meaning translate. My patients, if I'm talking about funding and my patient doesn't understand, then I tell them, you know, that's paper chasing. I'm gonna meet them where they are. If they don't understand a particular language, because I think sometimes there's a hesitance to break things down, especially if it's in a way that appears street or ghetto, out of fear that we appear less intelligent. No, that's not the case, because actually the most of the best ideas, if not all, that's where they originate from. So if my patient doesn't understand what I'm saying in a professional sense, then I'm gonna break it down. If you understand paper chasing as opposed to funding stream, that's what I'm gonna say. We also need to make sure that education is ongoing, and it is not in reaction to, but it's in preparation for. Whether that education can lead them into, again, workforce development. It can also help us to really stretch what workforce development looks like. So invest. We have to invest. They want us to do all these different things, but there's no real investment. We have a channel for everything. How come we don't have a channel for, cancer community communications, where we break it all the way down? They got CNN in it. So, we can have YouTube stations that really break everything down and can take our time. We can create segments and have different doctors and community health workers and advocates and activists and patients, and just make something that's really very comprehensive, accessible, and be a real representation of who we are. If you want something that's more clinical and more professorial, click the link. If you feel like you want to click a TikTok version of whatever it's doing, click the link. But we can't take it. We have to just remember that we're a very, very diverse community. There are young people, there are older people, there are people of certain faiths, there are all type of different things. And our education approach, it can reflect all of that. One thing that we know as Black people, we know when you're talking to us, with us, and when you're not. And authenticity is very, very big in the community. And if you're scared to say ain't, well then, honey, I don't know what to tell you.
Right.
Because my patients say ain't.
Right.
And just talk to them like it's somebody you love or you want to know. That's the way we educate our patient. Come from a position of love and try to have things as readily available as we possibly can, and don't be afraid to break it down.
Love it. All right. So we absolutely want to follow and support Radical Healer, Radical Leader. We are here for it. And, in any language or words you want to use, we appreciate your work. How can we get a hold of you to connect, to learn more, and to support?
Well, I'm 59 years old, so I'm kind of outdated. So I have a LinkedIn. You can reach me through LinkedIn right now as I prepare for my launch. But again, you guys, thank you so much. Thank you, Rhonda, for this awesome opportunity. I'm very grateful, and I just want to thank everyone for all their hard work.
Thank you for all of your hard work. That was amazing. And thank you for just keeping it real.
Can I just interject for a second? So I want to say thank you to Z for a number of reasons, but thank you for sharing all that you did with us today, and your passion. It definitely comes through. And I also want to say this is a full circle moment for me, because as you know, you and I met at the California Black Health Network's Black Health Agenda session in Oakland about 5, maybe 6 years ago. And we knew when we met that we had this connection and that we would do some work together. And I know we attempted to do that at Highland Hospital with Dr. Curry, but happy that we're both here and could be present today, and happy that you were able to, speak your word and drop some knowledge on us today. So thank you so much. I just wanted to say that. And thank you also for mentioning the Cancer Care Act. We were a co-sponsor of that.
Right on.
And for validating the importance of, what that means for patients in Medi-Cal.